Ms. Cecilia Taglic-Ronalm. I'm the newly elected CVT liaison for the state of Arizona. Tonight, we're going to be talking a little bit, well, we have a featured speaker tonight. Andrew Flom is going to talk about VT versus SVT, and then just a differential VTS versus the SVT on 12-lead EKG. But for a few minutes, I'd like to make some announcement in terms of, I don't know if you can see my screen here. Are you able to see it?
Not yet.
Not yet. Okay.
There you go.
Yep. There you go. Okay. So as most of you know now that the annual scientific ACC for this year have become all virtual from the hybrid that we were initially planning on, just because of a lot of this restrictions, still travel restrictions that's going on. But it's still a really good learning opportunities, whether it's hybrid or not, or whether it's, virtual or not. So registration is currently open right now. Especially the advanced registration is open until I think March 31st for that. So please, if you're interested in attending this great opportunities for learning, please register for this. And then just for the local events, we have a Phoenix Heart Walk that's going on right now, actually this weekend. That's the digital Heart Walk that's going to be on Saturday, March 13th. Basically, this is just a digital virtual walk that you can do on your own where you live. This is a way to support the American Heart Association. And for the Tucson area, we have their digital walk as well. This is for the Tucson Heart Stroke Walk happening on April 24th, 2021. And still to remind everyone to encourage colleagues, friends to be a member of the ACC. There's still that code that's, to refer a code for free. That's the CVT Refer 21, and this code is still valid until August of 2021. Okay. Just breaking down the CVT membership here in Arizona. This is as of December of 2020. As you can see, the NPs and the CNS accounts for about 92 members for the whole group. There are 32 RNs, 10 pharmacists, 18 PAs, and the other are either physical therapies, dietitian, administration, and some didn't actually identify themselves. So we have really opportunity to increase our membership, either through the referral code or just encouraging them to join our group here for learning and educational purposes. So as far as our group here in the CVT in Arizona, we're actually forming some committees here for research and education. Barbara Novaes from Mayo Clinic has actually agreed to lead that committee. And then we have Christine Babb, a physician assistant, also agreed to be leading the membership and outreach committee. And then we're still looking for an advocacy and legislative committee. If anyone's interested to lead this committee, please feel free to email me with my email down below. Then without further ado, I'd like to introduce our featured speaker for tonight. His name is Andrew Flom. He's actually a Mayo Clinic Cardiology NP Fellow. He's a graduate of University of Michigan. And without further ado, here's Drew Flom. Welcome, Drew.
I'm gonna share my screen here. You'll just have to stop sharing your screen and then I can jump right in. There you go. Perfect. All right, let's see. Okay, can you guys see my screen? It should just be the PowerPoint here.
Yeah, we can see it, Drew.
Okay, is it just the PowerPoint, or do you see the black screen as well with the upcoming slides? Because I don't want to give you guys the answers in the notes over here.
Just the blue screen.
Okay, all right, perfect. So, yep, thanks for introducing me, Cecilia. Yeah, I went to the University of Michigan, did the acute care track, and now I'm doing the cardiology fellowship here at the Mayo Clinic Arizona campus. So I want to thank Michelle Allen and then Cecilia for kind of creating this opportunity for me. I see a lot of familiar names in the participants here. So we have some really good content to cover. So we're going to be talking about, and again, throughout this presentation, if my audio or the visuals are messed up, just feel free to cut in and let me know. So we're going to be talking about wide complex tachycardias, focusing on the Brugada's criteria. No disclosures. So the learning objectives, we're going to talk about the importance of differentiating wide complex tachycardias. We'll go through the Brugada criteria as well as defining axis precordial concordance. And hopefully by the end of this, we will have developed a systematic approach to kind of breaking down wide complex tachycardias on the 12 lead. And so I have a few cases at the end that we can practice going through. So tachycardia classifications, for the purpose of this discussion, we can break them down into narrow complex and wide complex tachycardias using the QRS restoration of 120 milliseconds as the defining characteristic. We're going to focus on ventricular tachycardia and SVT with aberrancy. Here are some of the other examples of wide complex tachycardias that we'll go through here, which is our differential diagnosis, which we should think about, obviously, VT, SVT with a bundle branch block. If there's aberrant conduction, SVT in the setting of electrolyte or metabolic disturbance, SVT with an accessory pathway, and then also paced rhythms. Also keeping in mind patients who have a history of SVT that are taking class 1C antiarrhythmic agents, they are predisposed to prolonged QRSs as well. So these are all of the things that we should be thinking about when we encounter a wide complex tachycardia on the 12 lead. So why is this important? Well, the big takeaway from this is that the treatment for VT and SVT are very different. And so using the Vaughan Williams antiarrhythmic drug classics for VT, generally we would reach for the class 1B agents like lidocaine or mexiletine, or class 3 agents like amiodarone or sotalol. And so for SVT with without pre-excitation, I should say, we're generally reaching for rate control agents like class 2 beta blockers or class 4 non-dihydropyridine calcium channel blockers like diltiazem, verapamil. And so in SVT with pre-excitation, we generally reach for the 1A agents like procainamide or the 1C agents like flecainide and propafenone. And so the purpose of this isn't really for you to memorize what agents we use as typically first line. It's really just to understand that the treatments are much different. And so another note I want to make sure we take away from this is that AV nodal blockade in the setting of acute VT in SVT with pre-excitation precipitates hemodynamic compromise. So VT sort of progressing to ventricular fibrillation and SVT sort of following the same fashion. And so I have a slide here kind of breaking this down a little bit more before we jump into VT versus SVT. I want to touch on pre-excitation because I think it's an important concept that we should always keep in the forefront of our mind whenever we encounter an ECG. Classically, when we talk about pre-excitation, WPW or the Wolff-Parkinson-White syndrome comes up. And really it's characterized by an accessory pathway called the bundle of Kent. And we can think of this accessory pathway sort of as a backdoor approach to stimulating the ventricles. This accessory pathway is not subject to the same sort of AV delay that our AV node has. And so if we use AV nodal blocking agents in the setting of pre-excitation, this increases the electrical activity through the bundle of Kent, predisposing these people with pre-excitation to tachycardia and subsequently VT or VF. And so the way that we characterize WPW on the 12 lead is this classic delta wave, this up slurring of the QRS complex. We're avoiding AV nodal blockade alone, and then these are some of the agents that we reach for. And obviously, if they're unstable, we would do a cardioversion. So that is the pre-excitation soapbox. We will now kind of jump into differentiating VT and SVT. And so throughout the next few minutes, we will talk about axis, precordial concordance, and we will break down the Brugada criteria going through each of these steps individually. So axis, this presentation kind of assumes that we have a general understanding of how axis works, but we'll spend a couple minutes here just kind of breaking this down. So the axis refers to the direction of depolarization as it passes through the myocardium. So the mean QRS vector as it travels through the heart. And so a normal axis is typically defined at about 0 degrees and positive 90. Some sources will say negative 30 and positive 90, but generally the mean QRS vector is moving in this sort of downward into the left sort of area. And typically the leads that we jump to when we're first learning about axis is lead 1 and AVF. And so having all of these limb leads here, I want you to think about each of them as a positive electrode. And whenever an electrical signal moves toward a positive electrode, we get an upward deflection in our QRS complex. And so if we have a normal axis, like in a structurally normal heart with a normal conduction system, we should expect to see a normal axis. And so if it's moving in this direction here, we would expect to see a positive deflection in lead 1 and also a positive deflection in lead AVF. And so in order to sort of recognize VT, we need to understand deviations from the normal axis, such as right axis deviation, left axis deviation, and then extreme right axis deviation here. So for VT specifically in regard to axis, we are looking for extreme right axis deviation, also called northwest axis deviation. And so this is called northwest axis. If we think about north, south, east, and west, northwest would be somewhere over here where lead AVR is. And so specifically with northwest axis deviation, we're looking at lead AVR. And if we have a positive QRS vector in AVR, that is evidence for ventricular tachycardia. Also of note, if we have a right bundle branch block with left axis deviation and left bundle branch block with right axis deviation, this is all suggestive of ventricular tachycardia. Now, this is not definitive evidence for VT. This is just really just evidence toward the diagnosis. It's not definitive. So just increasing our suspicion. So again, northwest axis, we're looking at AVR. If there's a right bundle, there's left axis deviation, a left bundle with right axis deviation, all evidence for VT. Precordial concordance, we're looking at leads V1 through V6. And on the left here, we're specifically looking at positive concordance. And that refers to the upward deflection of the QRS complex. And we have that upward deflection in V1, 2, all the way through V6. So this right here on the left side is an example of positive precordial concordance. And this is evidence for ventricular tachycardia. And on the right, we have an example of negative precordial concordance, where all of the QRS vectors are displayed downward from V1 all the way through essentially here V6. They're predominantly negative. So if we have positive concordance or negative concordance, this is evidence for ventricular tachycardia. Now, using the axis and precordial concordance, this is not definitive evidence for VT. These are all things and tools that are increasing our suspicion. The next approach here is to get into the Brugada criteria, which is a stepwise approach favoring VT. But before we do that, we'll quickly recap all of the things that we discussed so we don't forget it as we move forward. So we talked about pre-excitation. We're looking for the delta wave. We're avoiding AV nodal blocking agents. We're looking at the axis. If we have a northwest axis with a positive QRS vector and AVR, a right bundle with left axis deviation, a left bundle with right axis deviation, all suggestive of VT. Looking at precordial concordance, all of the QRS vectors are positive in V1 through V6, or all of them are negative, all suggestive of ventricular tachycardia. Now, the Brugada criteria, stepwise approach favoring VT, meaning that we start with step 1, and if we do not satisfy the criteria, we progress to step 2, 3, and then subsequently 4. All of these steps ask a question. If the answer is yes to that question, diagnosis of ventricular tachycardia can be made. So before we jump in, this is essentially the same algorithm that was here previously. This just displays each of the associated sensitivities and specificities with each of the questions. So the first question being an absence of an RS complex in all precordial leads. If we don't have an RS complex, the answer is yes, and a diagnosis of VT can be made with a sensitivity of 0.21, but a specificity of 1.0. And you can see the associated sort of sensitivities and specificities as we progress through the Brugada algorithm, ultimately ending with a diagnosis of VT with a sensitivity of 0.987 and then specificity of 0.965. So we'll jump into the first step of the Brugada criteria, and we're looking at the RS complex, specifically, as we said, the absence of an RS complex in all precordial leads. Look up in the right here. This is an example of an RS complex. We have this upward deflection of the R wave followed by this downward deflection of the S wave. We're not looking for QRS complexes. We're not looking for QS complexes. What we're looking for is this sort of morphology, the R wave followed by the S wave. And so on the left side here, if we're looking for this RS complex, we really don't see any. And so if we don't see any RS complexes, a VT diagnosis can be made. However, if we're presented with the 12 lead on the right, the first thing we do is look for RS complexes. And you see with the red arrows, these are indicated in V3 all the way through V6. We have this upward R wave followed by a downward deflection S wave. And so for that reason, if we have RS complexes, we have to move on to step 2. So we have RS complexes. We're moving on to the next question. What do we do? Well, the R to S interval greater than 100 milliseconds in one precordial lead. So now we know that we have an RS complex. Now we have to measure it. And if it's greater than 100 milliseconds, a diagnosis of VT can be made. So we're looking at the RS length, the R to S interval greater than 100 milliseconds in one precordial lead. So how do we measure the RS interval? Well, if you look down here in V6, we have these two black lines. And so we're starting from the beginning of the R wave and we're ending at the terminal portion of the S wave. And this is our R to S interval. And in V6, they have a measurement of 70 milliseconds, which is less than 100. And this sort of example displays the importance of measuring the R to S interval in all of the precordial leads. Because if we came up to V4 and we measured from the beginning of the R wave to the terminal portion of the S wave, we'd get an RS interval of 160 milliseconds. It's really long. And this satisfies the criteria for VT because it's greater than 100 milliseconds. So to really hammer that point home, if this R to S interval is greater than 100, we can make a diagnosis of VT. But if the R to S interval is less than 100 in all precordial leads, we have to go to the third step. So the third step, summarizing here, we have RS complexes, and now the RS interval is less than 100. So now we're going to the third step of the Brugada criteria, and we're looking for atrial ventricular dissociation. If we have AV dissociation, a diagnosis of VT can be made. So AV dissociation. the P waves are present at different rates compared to the QRS complexes. The top portion of the heart is not communicating synchronously with the bottom portion of the heart. And so if we have that, if the P waves are occurring at different intervals to the QRS complexes, we can say, yes, AV dissociation is present and a VT diagnosis can be made. And so on telemetry here, this is a very subtle finding, but this arrow indicates essentially a buried P wave in the T wave, producing this sort of different morphology that we see here. And then this yellow circle is another P wave preceding the QRS complex. And so to fully think about this, you want to think about ventricular tachycardia, an ectopic focus originating somewhere here in the ventricles, traveling retrograde back up toward the heart. And so the top portion of the heart is not communicating effectively like a normal intrinsic rhythm. So we have this ectopic focus that's firing and firing retrograde. And so the SA node is still functional. It's just none of the impulses are getting through the AV node because all of this, the bundles are in refractory. So the SA node is firing, 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 but not necessarily in relation to this ectopic focus that originates here in the bundle branches, or the rest of the ventricle. So here's another example, a better example, I would say, of AV dissociation. So we'll look specifically here at lead 2. These arrows indicate P waves occurring at different intervals in the cardiac cycle in relation to the QRS. And so this is a very subtle finding, but you can see that this T wave essentially looks different than the other ones. You can see minor notching that indicates the P waves are occurring at different intervals. And so this is displayed in lead 3, AVR, and AVF by these arrows here. A very subtle finding. So we talked about P waves occurring at different intervals in relation to the QRS complex. That's AV dissociation. There are a couple other ways that we can determine that AV dissociation is present. And one of them is being the presence of capture beats. And so that's when the SA node transiently captures the ventricles during AV dissociation, producing this sort of narrow, normal, intrinsic sort of QRS complex when compared to these ones over here on the left. So imagine this ectopic focus originating here in the ventricles, firing retrograde. And so the P waves, the signals are still coming from the SA node and they're reaching the AV node. It's just all this tissue is still in refractory. Well, occasionally one can sneak through and depolarize the tissue in a semi-normal fashion, producing this narrow QRS complex. And so that's what a capture beat is. In red here, this is a fusion beat. And so essentially, if we were to take this wide complex tachycardia QRS and this capture beat and sort of add them together, summarize them, we would get this fusion beat. It's kind of a combination of both the wide complex tachycardia and then the narrow intrinsic QRS complex, producing this hybrid fusion beat. So to summarize, we have P waves occurring at different times in relation to the QRS complex. We have capture beats and we have fusion beats. If we have any of these present, this indicates AV dissociation and a diagnosis of VT can be made. So if we don't have AV dissociation, we have to go to the fourth step of the Brugada criteria. Before we move to the fourth and final step, let's take a second just to recap all of the things that we talked about. We talked about pre-excitation. We're looking for the delta wave. It can be very subtle and present maybe only in 1 or 2 leads on the 12 leads. So we have to examine all leads for the delta wave. We're avoiding AV nodal blocking agents to prevent increased electrical activity through the accessory pathway. We talked about the axis, northwest axis, a positive QRS vector in AVR. And we also said if you have a right bundle and left axis deviation or a left bundle and right axis deviation, these are all suggestive of ventricular tachycardia. We talked about precordial concordance, upward deflection of all of the QRS complexes in V1 through V6, or negative deflections in V1 through V6 signify precordial concordance, and it is suggestive of VT. We looked at the RS complex. We measured the RS interval. We looked for AV dissociation P waves occurring at different times in the cardiac cycle compared to the QRS complex, as well as capture and fusion beats. So we haven't satisfied any of the Brugada criteria at this point. We have not made a diagnosis of VT. We're going to the fourth and final question, and that is looking at the morphology criteria for VT, and specifically we're focusing on the leads V1 and 2 and V6. And so if we have the morphology criteria, a diagnosis of VT can be made. And so we're going to explore this a little bit further. So again, we're looking at leads V1, sometimes V2, but for simplicity, we're going to focus on V1 and V6. And the morphologies that we're looking for is an atypical right bundle or a left bundle branch block. And so once we've determined that, we can look at the specific measurements and determine if this rhythm satisfies the criteria. So here is an example of a classic atypical right bundle branch block. And so in V1, we have this sort of monophasic R wave, and then in V6, we have this predominantly negative downward QRS deflection. And if we think about a normal intrinsic rhythm, we have this nice R wave progression that typically produces an upward deflection in V6. This is the different classic morphology of an atypical right bundle branch block. And the reason that we say atypical right bundle branch block is because our classic typical right bundle that's displayed here is more suggestive of SVT. So we are focusing on an atypical right bundle, not the typical right bundle, okay? And so then here's an example of a left bundle branch block, sort of this more like QS sort of pattern, and then in V6 has this QR wave. And so we'll break down each of these individually to fully understand what the morphology criteria is. So if we have an atypical right bundle, the first thing we're looking at is V1. And we only have to satisfy only one of these criteria in order to say, yes, V1's criteria has been met. There's a couple things that we could use. If we have a monophasic R wave, meaning that the upward deflection is predominantly upward and then downward, monophasic, that satisfies the criteria for V1. If we have a notched downslope in the R wave, that does as well. And so also a QR pattern. Then we go to V6 and we look at the R to S ratio. How big is the R wave compared to the S wave? If our R wave is less, then a diagnosis of VT can be made. And so I understand that this is sort of the more complex criteria in the Brugada method, and it just takes practice and essentially a little bit of memorization in order to remember it. If we have a left bundle, so we've already went through the atypical right bundle branch pattern. If we have a left bundle, though, again, we're always going back to V1. We're looking at the R wave, and if it's greater than 30 milliseconds, this satisfies the criteria. If the S wave is notched or slurred, this also satisfies the criteria, and then we can go on to V6. And this is a little bit easier. If there's any Q wave in V6 in a left bundle branch pattern, this favors VT. In V6 here, we have a QS pattern and then the classic QR. And so I understand, again, it just takes memorization and a little bit of practice for this last step. Okay, so some VT pearls. We talked about the northwest axis. We talked about the right bundle branch pattern with left axis deviation and a left bundle with right axis deviation. Positive and negative precordial concordance, all increasing suspicion for ventricular tachycardia. As we got into the Brugada criteria, RS complex, RS interval, and then AV dissociation. We're looking at the P waves in relation to the QRS, right? And we're looking for capture and fusion beats. Focus on that atypical right bundle branch pattern because the typical right bundle, that RSR prime pattern, is more suggestive of SVT. So the purpose of this discussion, we're really focusing on things that are VT. Okay, so atypical right bundle and then that left bundle pattern. I added these two here at the bottom, the Josephson sign, and that is, I have an example of that right here, notching at the terminal portion of the S wave And we can see that little tiny notch right here would be Josephson sign. So that's just another little extra tool to keep in your tool belt when you're evaluating wide complex tachycardias. Additionally, a notched downward slope in AVR is suggestive of VT as well. So a stepwise approach to breaking down wide complex tachycardias on 12 leads, similar to how we would interpret any 12 lead. However, we're starting with the rate, then we're looking at the rhythm, the QRS morphology. If we can measure any of the intervals, we're examining the axis for that northwest axis. Is it a positive AVR, right bundle with left axis, left bundle with right axis, precordial concordance, RS complex, RS interval greater than 100, AV dissociation, and finally QRS morphology. So now I have a few case examples here. I was wondering if anyone feels comfortable breaking this down. I kept the stepwise approach up here in the corner. We can do it together, or if no one feels comfortable doing that, I'm happy to break it down for you guys as well. So we'll just take a second and see if anyone wants to volunteer.
Hey, Joe, it's Mallory.
Mallory.
You want to walk it through with me?
Yeah. So first thing,
Well,
we're starting with the rate here, right?
Yeah. Okay, cool. So I'm going to take a stab. Look here. It looks about like the rate could be about 300. Looks like the rhythm. Do I see any P waves? I don't see any P waves. At the bottom.
Yeah, there's some P waves here at the bottom, but this is a longer little telemetry strip that we have here. I see some maybe here, but I agree with you. Like up in this area, I don't really see anything that's kind of sticking out as a P wave here. So the rate here, we a few lines apart, it looks like 300, 150, 160-ish, right? I don't see any P waves either. What do you think about the axis?
Okay, so we're upright in V1. It looks like we're downward in AVF. So possibly LAD. What do you think?
Yeah, so exactly. We're downward in our inferior leads. We're downward in AVF, like you said too, and then we're upward in AVL and in AVR. So we have a largely superior axis here. And so our QRS morphology is an atypical right bundle, and then we have possibly left axis deviation, more of a superior axis. And so what do you think about precordial concordance?
Right, so predominantly, so I'm looking more so in V2, V3, they look like it's predominantly upright.
Yeah, I agree. Upright in V1, upright in V2, maybe upright in V3. We're getting a little more like isoelectric here, but then we have a flip here in V4. Our QRS is downward, right? In V4, V5, and V6. So no precordial concordance, but that's okay because we said before that precordial concordance is just suggestive, not necessarily definitive. So we have a widened QRS complex at 200 milliseconds, just gigantic, an atypical right bundle with, a superior sort of axis. So we're kind of thinking, possibly VT. Let's go through Brugada's criteria to really see if it is. And so the first step, we need to see, do we have any RS complexes? And so the answer, right, is yes. If you look at V6, right here. RS complex, this tiny little wave followed by the S wave here. And so if we have an RS complex, we have to go to the second step.
RS interval.
And the second step is measuring the R to S interval. And so what do you think about that? Do you think that it's greater than 100?
Let me see, R to S, E, so greater than 5 little boxes.
Mm-hmm.
So let me see in this one as well. It has to be more than 100, correct?
Oh, for sure. Exactly. Yeah. I mean, the QRS complex is greater than 200 for sure. So this RS complex is like 160, 140-ish if we're measuring from the beginning of the R wave to the terminal portion of this S wave here. We're getting, 160, 140-ish. So way bigger. So at this point, a diagnosis of VT can be made. We don't have to go any further, but now that we know this is ventricular tachycardia, for the sake of academics and everything, we should look for AV dissociation just because it's a really, really good example. And you can see the wide complex tachycardia at the bottom, just tacking along. And then we have this sort of weird hybrid beat followed by what appears to be this normal, their normal intrinsic rhythm. So my first thought is to say that this is probably their intrinsic capture beat, what that would look like. And this seems to be more like a fusion beat, sort of a summation of this intrinsic rhythm and the wide complex tachycardia. So we have fusion beats here. And so this is evidence of AV dissociation. If we didn't feel comfortable with the RS complex measurement, we could make the diagnosis of VT based off AV dissociation at this point. However, because we know it's VT and it's a really good example, we can go to the fourth and final step just to check the QRS morphology. And as we said, this is an atypical right bundle branch pattern, right? This is a predominantly monophasic R wave. There are little notches in there, but not enough to signify, the more typical pattern, right? This is just a monomorphic pattern, predominantly going up and down. So we satisfy the criteria in V1. And then if you look at V6, we're looking at the R to S ratio, right? And if that R to S ratio is less than 1, then this satisfies the criteria. This R wave is so small. S wave is very large. Obviously, this is less than 1, so we satisfied the criteria in both. Again, diagnosis of VT can be made. So I just thought that was a really good example, and I wanted to walk all the way through it. However, the take-home point is the Brugada criteria is a stepwise approach. And once you meet the diagnosis for VT, you do not need to progress to the next steps. A diagnosis of VT can be made. However, if you are unsure if this RS complex was borderline, if you thought maybe it was 100 or 90 or 110, you can progress to the next step. Obviously, you wouldn't be satisfying the criteria. So that's really just the takeaway point from this. So I appreciate you going through that, Mallory.
It has me excited. It has me excited for my EP rotation. So thanks.
Yeah, you won't get enough of that stuff. So we'll go to the, I'll come back to this one. We'll start with this one here. If anyone else feels comfortable sort of breaking this down or breaking it down with me, that'd be great. If not, I can break it down. It's no issue at all. So.
I recognize a lot of these names. Can I play popcorn? just teasing. I'm not going to.
Yeah, it's all right. It's okay. I'll break it down here. So I have all the answers anyway, so it's kind of cheating. But initially, we'll just follow the stepwise process. We have this wide complex tachycardia. They come to us and say, what the heck is this? Hopefully, their blood pressure is stable. However, we're starting with the rate here. And so we go 300, 150, so a little bit greater, probably about 160-ish. The rhythm, we have a wide QRS complex, again, greater than 200. We have an atypical right bundle pattern. And now we can jump to the axis. Immediately sticking out to me, AVR is upright. So we have this northwest axis deviation, which is suggestive of VT. We are a little more isoelectric in AVL, so predominantly an extreme right axis deviation in the setting of an atypical right bundle range pattern, okay? So that just goes to show you that everything isn't textbook. If we have an atypical right bundle, we might not have left axis deviation, but we do have some northwest axis deviation. So kind of keeping all of these concepts in mind and then applying them as we move forward. Precordial concordance, the QRS complex is predominantly upright, isoelectric, and then a little bit more negative as we progress through. So no precordial concordance, but that's okay. We said it was suggestive for VT, not definitive. So without further ado, we can jump into the Brugada criteria, right? First thing, do we have RS complexes? If we don't, we can make a diagnosis of VT right away. But we do have RS complexes, especially check out V6. That's a really good lead to look for the RS complexes. So we have this upward R wave followed by a downward S wave. And that's the morphology that we're really looking for. We're not looking for QRS complexes. We're not looking for QS complexes. It's RS complexes. And we do have one. So we have to go to step 2 and measure the RS interval. So from the beginning of the R wave to the terminal portion of the S wave. And we can see that this is 40, 80, 120, 120 milliseconds consistently. And so remember, we have to measure it in all of the precordial leads. I chose V6 here because I could see that it was essentially greater than 100. But as the example showed before in the teaching portion of this, V6 was measured at 70 milliseconds, and then V4 was measured at 160. So we have to really appreciate all of the precordial leads because all the measurements are different. So we have an RS complex, and the interval is greater than 100. So a diagnosis of VT can be made at this point. So we really don't need to move on any further. For the sake of academics, we can look for AV dissociation. We have a very long telemetry strip down here, and there are little kind of incremental notches that could potentially be P waves. It's really difficult to say. And at this point in my career, I wouldn't feel entirely confident saying, yes, AV dissociation is present. Maybe, the more developed eye would say so. However, it's difficult for me to tell. It's very subtle. So I'm going to move on to the fourth and final step of the Brugada criteria, and we're going to see if we meet the morphology criteria for it. So we have an atypical right bundle, right? We have this monophasic R wave, so V1's good. We're going to move to V6, and we're looking at the R to S ratio. The R wave is much smaller than the S wave, and so we satisfy the criteria in V6. And so again, a diagnosis of VT can be made. However, just to remember the take-home point, we do not need to progress any further once the diagnosis is made. This is just for the sake of academics and then applying the ECGs here. We have a few more examples, but I think I'm just going to choose one more to go through just because we talked about it so much. So we'll break down this last 12 lead here. We're starting with the rate. And we'll see this is 300, 150, probably about 140 or so. It looks like a narrow QRS here. If we measure it out, it's probably, maybe 100 milliseconds or so, maybe borderline. So relatively normal. It does look a little bit wide and it's kind of tough. And so, but what's really sticking out to me on this ECG, which is why I wanted to go through it, is this up slurring of the QRS complex. It's very subtle. And so in the teaching portion of this presentation with pre-excitation, it's very exaggerated, the delta wave, but you can see this change is just very subtle. Another tip-off point is the PR interval. And so if we measure that out, it's 40, 80, it's almost about 80 milliseconds, 80 to 100 milliseconds. So it's less than 120. So we have a short PR interval. And that's one of the things that should tip you off to maybe there's pre-excitation here. And if we were just looking at V6 or V5, you can barely see that delta wave. And so this is just an example to highlight the importance of examining all of your leads for pre-excitation, because the treatment is much different and choosing the wrong agent can be detrimental to the patient. So let's see, we'll continue progressing to see if it satisfies any of the Brugada criteria. We're looking at the axis. Predominantly we're upward in AVF and the inferior leads. So we have a generally normal axis. Here's lead 1, we're isoelectric and we're down in AVL. So I can say that we have a predominantly normal axis, normal QRS interval, short PR. And so now let's see, all right, if we're still not sure for some reason, and we didn't pick up on that delta wave, let's go through Brugada's criteria. Do we have an RS complex? And so, maybe here, yeah, we can call this an RS complex. It looks very short. So if we do have one, we're going to measure it out. And it's obviously not greater than 100. So we'll go and see, do we have AV dissociation? We're looking at this bottom telemetry strip here. We can see there's a P wave before every preceding QRS. Now we can't be certain that something isn't buried within the T wave. Maybe something else is going on, but we can say that these P waves are associated with each preceding QRS complex. So no AV dissociation that I can see, no capture or fusion beats. Moving to the QRS morphology, if you look at V1 and V2, this is a kind of a classic right bundle pattern. And that's not what we're looking for. We're looking for the atypical right bundle. And this is more suggestive of SVT. And so we haven't satisfied any of the Brugada criteria. This is not VT. This is an example of Wolf Parkinson White in the setting of SVT, given the rates, 140, 150. So I think that will be good for the case examples. I had a few more here, but examples of AV dissociation here, pretty good stuff. And then here's a paced rhythm, tachycardic rhythm at the end for everyone to take home. But that's kind of my presentation here over the Brugada criteria. Does anyone have any questions or any discussion points?
Drew, this is a very excellent talk, and the way you go step by step, systematic way of reaching diagnosis of ventricular tachycardia.
Cool.
I
Awesome.
applaud you
Thank
for
you.
that.
I'm glad you liked it. I was excited to give it to you guys. So I think it's a really good overview for new providers, but also, for people who've been in the game for a while, it's a nice kind of brush up on the foundational sort of systematic approach.
I agree. Thank you very much, Drew.
Yeah, you're welcome.
Do we have any questions or comments from the audience?
Nope.
Well, thank you again for joining us for our first CVT meeting this year, and hopefully we'll have more to come. And again, thank you, Drew, for giving us an excellent talk on how to differentiate between VT and SVT in a very systematic way. So we look forward to hopefully having a virtual meeting, at the ACC, and hopefully in person later during the year as we get through this pandemic.
Cecilia, I noticed you were recording today's talk, or is this going to be on the Arizona ACC webpage for future reference, or?
Leanna is in charge of the recording. I do believe, if you correct me if I'm wrong, Leanna, is that going to be available? I think she left. I will reach out to her and see where this recording will be posted. Who's asking the question so I can send a.
Oh, Cecilia, it was just me, Michelle. Michelle, thank
Michelle,
you.
okay,
Yeah, no worries, no worries.
I'll
Yeah.
reach out to Leanna and see if where is this recorded and where is this going to be posted. Anybody else have any questions, comments? All right, I think we will end this meeting. And again, thank you everyone for attending our first CVT meeting for the year. And we look forward to, again, meeting each other.
Thank you, Cecilia.
All right,
Thank
have a
you.
good night.
Good night.
Thank you.
Thank you.